appreciated, and he basically highlighted most of my presentation, so it's going to make my job much easier. I'll start by defining constipation. The definition of constipation is very, very important for our work, because a lot of patients are referred for MRI that are not actually correctly referred, because constipation is it's considered one of the diseases, but actually it's not a disease, it's actually a symptom. It is a very subjective symptom, and if you ask a patient from one to another, you'd find different understandings. So what we say, it's basically the most important thing is both infrequent defecation and difficult evacuation. The most general and accepted term that it's an infrequent stool less than 3 times a week with difficult evacuation, where the patient would spend more than 25% of his time inside the bathroom trying to strain. Must be a very exhausting condition, of course. But when it comes to constipation, there is a myriad of reasons and causes that eventually cause this symptom. So everyone here, I would assume, had ever complained of constipation once, but probably didn't do an MRI, because there's dietary conditions, there's lifestyle. Basically, if you repress the defecatory urge, that would affect you and cause constipation. But there are also secondary causes, patients with diseases like Hirschsprung disease, presence of outlet obstruction in terms of malignancies, some types of drugs, patients with neurological conditions like MS, spinal trauma, even depression. So these are all secondary causes. What about the primary causes of constipation, which is the most important part? For us as radiologists, and today I will be more concerned with the evacuation disorder, but I would like to say, as Dr. Abdurrabbu referred, that there's something called slow colonic transit constipation, and there's evacuation disorder where there's an obstructed outlet obstruction. In terms of slow colonic constipation, we need to understand that constipation or the defecation as an act is a complex process that starts since the person eats. So it's a complex that involves the entirety of the GIT. So if there's a slow motility, we do a specific examination. It's called transient time. I will not go through these details because I'm more focused on evacuation disorders. So what is obstructed defecation syndrome? It's basically the patient has an urge to defecate, but he has an impaired ability to expel this fecal bolus. Usually patients complain of a lot of symptoms, includes bleeding, but the most sensitive one, the most clinically relevant, that when the patient complains of it, you would assume that this patient has an obstructed defecation, is the digital rectal evacuation. And this is surprisingly more common than you expect. It's more common, obviously, in women, and the treatment involves a lot of options, it's not just surgery. Surgery, we might resort to surgery in some cases, but it also includes biofeedback and lifestyle modification. I'll talk quickly about anal incontinence and move then to the MRI. So what is anal incontinence? It is basically the involuntary loss of fecal matter or flatus at an inappropriate time or place. We generally classify it as if there's an urge or passive or nocturnal incontinence. What is urge? Basically that the patient can't get to the bathroom in time. So basically this is more or less a voluntary loss, voluntary damage, which affects the external anal sphincter. I'll move to this in a bit. Or passive, which is basically the patient wouldn't feel an urge, wouldn't feel a need to use the bathroom, and yet would evacuate. And then nocturnal is during night, which is usually related to a neurological defect. So if we look at on the causes of incontinence, it is also a very complex, it has a complex etiology, and as radiologists, we should never simplify it by looking at the anal sphincter and saying, oh, the anal sphincter is fine, or there's a damage to the anal sphincter, because sometimes you'd find patients with some damage to the sphincter, but the patient is continent, and in other cases, you find the sphincter completely normal and the patient is incontinent. So as you can see, there's simple incontinence, which is basically stool consistency, as anyone would ever know. If you ever have diarrhea, you will not be particularly continent. So this is quite common, but this is not particularly related to what we do. But when it comes to anal sphincteric causes, for instance, in cases of obstetric injury, post-operative post-fistulectomy or hemorrhoidectomy, neurological conditions like spina bifida, patients with MS, advanced MS, sometimes even with diabetic neuropathy. And it's very important to know that there's also an idiopathic incontinence where everything seems normally on MRI, and even the neurophysiology of the patient would be normal. So basically, there's a complex process. yes, the integrity of the anal sphincter is important to maintain the continence, but in addition, the pelvic floor muscle state, the presence of anal cushions, which are like 3 distinct vascular pads, they also have a role, play an active role in maintaining the continence for the patient. Nervous control of the anal canal and the pelvic floor has to be intact, as well as the consistency of the feces. And also it is essential, as we said, like the compliance, like Dr. Abdurrabbu referred to, the state of the rectal reservoir itself. It has to be compliant and sensitive. They all play a role in incontinence. So what is our role as radiologists? As Dr. Rania referred and as Dr. Abdurrabbu mentioned, when we do an MR defecography and MRI pelvic floor, we have to have a wider approach. We have to look at the pelvic floor as consistent of 3 compartments. It's not just the posterior compartment. I know I'm more focused on posterior compartment today, but we have to comment on everything. We have to be aware of the pathologies that happen in the anterior compartment, middle compartment, and posterior compartment. Why does this matter? Because as they mentioned, pelvic organ descent widens the levator hiatus. So you can imagine that the organs are competing for the same outlet. That could impact the patient's symptoms. So if you do a surgery or you focus your attention on one particular compartment, the patient you would fix part of the problem, but then the other organ will still compete for the same space because it's a similar space. So it is essential to understand why we focus on the 3-compartment approach. So my absolute focus today is on the posterior compartment disorders, and I like to classify them as structural and functional disorders or abnormalities. Structural would be basically, you would see something that it's not supposed to be normal, and it would cause the obstruction. While functional is like, there's a change in the function, there's an abnormally functioning structure. And there's somewhere between the solitary rectal ulcer, which I will talk about in a bit. So first of all, the rectocele is basically a bulging of an anterior rectal wall. You can see it over here. Bulging of the anterior rectal wall beyond the expected anterior rectal wall. It's usually clinically significant when it's more than 2 centimeters, but it can present in normal volunteers. So it's not essential. The patient has to be complaining as well. We grade it using the grade of the rule of 2, which is small, moderate, and large, based on 2 centimeters, 2 to 4, and 4. Typically, it's more anterior. It can occur posteriorly, usually more post-operatively. And what is most significant is that we have to comment whether the rectocele is trapping or non-trapping. So if it's trapping, means that the fecal residue would stay there. So patient would have to basically resort again to distal rectal evacuation. So it's an important part of our report to mention the rectocele is trapping or non-trapping. What about rectal prolapse and rectal intussusception? I like to describe rectal intussusception to residents as a sock. You know, when you're folding a sock into the other one. So basically what you see is like the rectum folds upon itself. So intussusception is basically circumferential prolapse within the confinement of the rectal ampulla. It has an internal and when it goes external, it becomes a complete extraanal rectal prolapse. But within the wall, within the levels of the rectum, there's a common way to grade it. It's called the Oxford grading system of the rectal intussusception. It is relevant because this invagination, this changes can obstruct the rectal lumen and cause the patient the sense of incomplete evacuation, that the patient might think that there's still fecal matter and continues to strain, even like he's evacuating. Or sometimes it causes the intrarectal residue. It is important to mention that you can classify it into low grade or high grade based on where it is in the level. So there is high rectorectal, which is basically more proximally. If you go further a little bit, it's going to be low rectorectal. That usually goes within the degree of the rectocele. And then rectoanal can be high or low rectoanal. Depends on like the proximal aspect or the distal aspect of the anal canal. And obviously the external is when the complete rectal prolapse, when the rectum completely gets outside of the anal canal. Moving to the functional disorders, which is the defecatory dystonergia or anismus. Generally, there is an unknown etiology. We are not sure exactly why does this happen, but mostly on imaging we see it's either the problem is within the puborectalis muscle, which normally would relax when the patient strains, or there is also the anal canal. Normally, it relaxes when the patient strains. Treatment option can include biofeedback and training, which is basically potty training, and botulinum injection sometimes can also result to surgery. The most important thing on imaging is like the prolonged incomplete evacuation of the rectal gel. And this is the most important way, most sensitive way to diagnose this case. It's not about seeing a muscle or an anal canal that's not opening. It's just that the patient would clearly be straining on MRI and trying to evacuate, and yet he can't. So basically, in puborectalis dyskinesia, usually there is a lack of pelvic floor descent, while in spastic anal canal, there's usually, because basically the obstruction is more distally or proximally. So when you see that there's lack of descent, it's mostly because of the puborectalis is the problem, but when the pelvic floor descends towards the anal canal, so you would assume that it's more of an anal canal problem. Anal manometry is absolutely necessary in these cases to differentiate between them. This is actually from a paper from Dr. Rania that I actually really like. And it can show you perfectly how you can see here the puborectalis is there's the aberrant impression of the puborectalis muscle, and there's no descent below the PCL. While if you look here, you would find that there's excessive descent of the pelvic floor organs, and you can see over here that the obstruction or the occlusion, like the anal canal lumen, is not widened. So this can confirm that. Moving to the solitary rectal ulcer syndrome, it has been one of my interests since I was a resident because so many things are interesting about it. First of all, it's not solitary, and it's not necessarily an ulcer, and it's not necessarily a syndrome. So nothing makes sense in the name. But basically, it's essentially a histopathological condition, disease, where basically there is an ulcer, but it's not always an ulcer. It can be just, sometimes it can be a mass, actually. The prime role for imaging is to detect the associated structural and functional abnormalities or functional, because sometimes it's an overlap between both. So basically when there is an intussusception or there is simply the patient doesn't evacuate and there's anismus, and on a histopathological analysis we find that the patient has solitary rectal ulcer syndrome. I'll move to the cul-de-sac hernias for quick, and it's virtually a fourth compartment. I don't like to say it's part of the middle. It can be considered a fourth compartment. Basically, there's herniation of the peritoneum or the bowel loops or the sigmoid within the Douglas pouch. Usually, hysterectomy is one of the risk factors, and there's destruction to a fascia that we don't really see. So that's why we see it. I'll move to some quick cases just to review what we're seeing. Please, I'd like to get your attention. This is a 38-year multiparous female. Her main complaint is obstructed defecation. But I want you to look at the image and tell me what you can see. So as the patient complains of obstructed defecation, you would assume that the problem is only in the posterior compartment, but in this case, there is a major obstruction as well. That is because of the presence of the anterior seal, which is over here. So we can look in this. So in this case, in addition to the anterior seal, you can see the PCL over here. Oh, sorry, this is the PCL. There's also, for true and false, can you see a rectocele? There's a bulge beyond the assumed anterior. I guess there is. Is there a small cystocele over here? Yes. Is there rectal intussusception? Yes. The rectal infolding within. And there's also probably damage to the rectovaginal fascia, although we don't see it, because there's a lot of element of the pelvic floor that's a little bit weird. Like you don't really see it, but you see when it's destroyed. Let's move to a second case. This was a multiparous, also female. She was surprisingly very young. She was 25. She came complaining also of obstructed defecation. So I would like you to look at the image and tell me what you think. So we can see that there's kind of delay in the evacuation, but at the same time you can see that the anal canal is opening, and there's an abnormal structure that is causing the obstruction. Or I wouldn't say a structure, there's an abnormal function that's causing the obstruction. So I gave it away basically. So you can see that there is an aberrant puborectalis muscles that keep contracting here over here, and yet the anal canal actually opens at some point, so it's not really the problem within the anal canal. So it's a functional obstruction, and there's a prolonged incomplete voiding of the rectal gel, and there's an aberrant puborectalis muscle contraction. So I would say this is a defecatory dyssynergia secondary to the puborectalis dyskinesia. This is also an interesting case. Again, multiparous female complaining of rectal prolapse. and obstructed defecation. So what happens when you see over here? So can you see the rectum completely externally falling outside of the anal canal? Can you see an association? Someone tell me anything? You can see that there's, if you draw the pubic line over here, you can see that there's an element of descent of the urinary bladder base, as well as the uterus. You can see complete inversion of the rectus over prolapse. So there's global pelvic organ prolapse in this case. So although this patient came complaining of obstructed defecation, her symptom was only in one region. It has complete pelvic organ prolapse. This, I would, as Dr. Rania said, when it comes to MRI, we don't just look at the dynamic scan. We also need to do look at the static and the phecography. But in this case, this was a patient that had fecal incontinence after normal vaginal delivery, and this was the axial T2 of the image. Can you see that there's scarring and perineal tear that's actually reaching the anal mucosa? So if you can look here, there's scarring and fraying of the deep external anal sphincter all around here, like it's completely deficient almost. And you can see that there's a track over here, like there's it's not a track basically, there's a defect over here within the internal anal sphincter that's actually reaching the mucosa. So this is a grade 4 perineal tear. When we move to the MR, the phecography of this patient, we can see that there's evident descent of the anorectal junction. There's also descent of the urinary bladder. You can see something that's interesting over here. I don't know if you can spot it. Actually, let's move to the next slide. Over here. You can see on this image, as we said, there's pelvic organ prolapse, that there's a cystocele, that's a big cystocele, and there's a uterine descent, and most importantly, there's leakage of the gel through the tear. And you can see that there is a grade 4 perineal tear when the tear is actually reaching the anal mucosa, in addition to the fraying and distortion of the external anal sphincter. There's a very interesting paper about the role of MR phecography in this patient, that it's just, normally if you don't do MRI, you would just do sphincterotomy, like fixing the sphincter. But Dr. Abdurrab would say better. But in such cases, I think it was important to refer this to the surgeon, because it might imply a completely different management. This patient had solitary rectal ulcer. She was a young patient, and her main complaint actually was more or less diarrhea and incontinence rather than obstructed defecation. So if you can look at these images, and I would like to make it easier, I would like to show you over here. What you see over here, there's some eversion. This looks like the sock, as we said. So there's a rectal intussusception in this patient, and this is the one causing the obstruction. So sometimes with solitary rectal ulcer, patients can present with some sort of secretions, not necessarily just, she had bleedings and secretion, not necessarily just obstructed defecation. But on MRI, there was clearly a pathology that had to be corrected. So if you look at this patient, there's excessive descent of the anorectal junction. Below the PCL, there's also a moderate anterior rectocele associated with a low rectorectal intussusception. Associated with that, the patient had a pelvic organ prolapse. I mean, it's very mild. It was grade 1, so it's just 3 centimeters below the PCL, but it is relevant for the patient complaint. My take-home message is that the pelvic floor should be dealt with as a single entity. It's not just if the patient came to you complaining of obstructed defecation, so you shouldn't simplify it as, okay, this patient probably has something in the posterior compartment and you can do just conventional phecography. MR could be highly useful in that because it can affect the management for the patient. Thank you very much.